Hello, what's up, lovely people? I hope you guys are doing pretty well. I'm doing pretty fine. We're still talking about the urinary system, and I think this week is gonna be the last week. No, actually, it's not. I think the urinary system is actually the last section of this whole term. But we're still gonna be talking about the urinary system today. So we're still in the kidneys. Kidneys, what they do with the glomeruli, they filter blood. They filter where it's the electrolyte product in the blood. We're also gonna be talking about like some infection, stones, structural abnormality within the kidneys, things such as cystitis, interstitial cystitis, a bunch of other things. And yeah, so I just hope you guys stay tuned and let's just get into it, I guess. All right, so let's dig in. So first thing first, we're gonna be talking about UTI. I did talk about UTI a little bit more last week, but today we're gonna brush up a little and talk about some stuff I haven't covered last week, I believe. So commonly, especially in common especially in women, and the reason is because of the anatomical difference we have, which is the urethra. In female, it's way much more shorter, male longer. Therefore, it makes the likelihood of a female having an infection way much more higher than male. I'm not saying that males doesn't get infection or doesn't get UTI, but the likelihood of getting infection will be less when it comes to a male versus a female. So can also be upper and lower. So when it comes to making the difference, the way that I use it is upper will be anything that kind of make it look systemic, like your fever and chills, your nausea and vomiting. So this kind of make me like think about, all right, so it's upper. And lower will be things like dysuria, pain when urinating, this burning sensation and stuff like that. Make me think like, all right, so this is gonna be lower. Also must comment HAI, which is hospital acquired infections, because you have things like Foley's, which probably are not being taken care of, like people were not doing the Foley cares like they should every shift, or also people living like dirty Puric and macerated Puric for days. All the things I also want to add to when it comes to Puric, it's not because it's working that you gotta keep it in or leave it in, because I do know some people go right out, all right, it's working, I ain't gonna touch it because I know if I go put a new one, it's not gonna work. It gotta be changed. It gotta be changed. I'm not gonna let a Purix stay in for more than 12 hours, honestly. So there's that. Um, Causes of UTI, you have bacteria, viruses, yeast, and fungi. I'm not gonna really be diving into this, but the most thing, or like the thing you're trying to avoid when it comes to UTI is scar tissue formation in the bladder, because the more UTI you have, the more scar tissue or the more damage to the bladder. It can also cause renal scarring and renal failure. So these are the things that we are trying to avoid when it comes to UTI, scar tissue. The sets. We are just gonna keep talking, I guess. All right, my lovely people. Now we are talking about urethritis. I'm not gonna lie, I did struggle before I got comfortable with saying urethritis, and that's the reason why I'm gonna say it again. Urethritis for the people in the back who didn't hear me saying it right this time. Urethritis, inflammation of the urethra. You guys already know. We got the bladder. You got the ureters. Like the two little things from side to side, and then you have the urethra. That just like expose or where the period actually goes in order to leave the body. So this thing is infected right now. That's what we're talking about. Causes. What causes urethritis? So you have microorganism, of course, and you also have trauma, people playing like contact sport and then like heating, this specific area. This may also cause arthritis. Chemical hypersensitivity, you're using like specific soap or body wash or whatever the heck people be using nowadays, to not making this smell a specific way or make it smell a specific way. Y'all be surprised about like the product we have out there that take care of them stuff. Crazy. Not FDR approved actually. All right. Back to arthritis. Common organism that cause arthritis. So we have E. coli, bacteria, sanitation. Make sure you know how to wipe. You don't wipe from back to front. You wipe from front to back, because you don't want to take all the stuff from the back to the front. You take all the stuff from the front to the back. Chlamydia, which is your regular sexual contact. Make sure you know who you're sleeping with or you're messing around with. trichomoniasis. This I've seen it. I don't remember when I've seen it, but I did look it up again. So it's from Trichomoniasis vaginalis, and surprising, one of them sexual contact yet again, but it also can be asymptomatic. So you guys really be careful about this because you might have it and you don't know. Gonorrhea, sexual contact, sexual hygiene, HSV2, sexual hygiene yet again. So you know who you're with and know who you're with well. And clinical manifestation. So what does urethritis look like? Dysuria, pain with urination, and then you're gonna go to the bathroom much more frequently or urgently. You also have bladder spasm, which can cause bladder leak, and discomfort. You also have urethral discharge, so white discharge or clear discharge are not supposed to be there. Diagnosis: how do you diagnose urethritis? You diagnose urethritis based on signs and symptoms and urinalysis, or you have a urethral smears. There is like no specific lab that will tell you like, all right, so this is positive for urethritis. So it's like multiple things, if I can say, or I don't really know how they call like the those kind of like disease processes or those like diseases where there's not a specific lab for them, but it's just like not a bunch of lab, but you gotta like do all the labs in order to confirm like the specific diagnosis. But you guys got the gist of it. So there's like no specific thing that'll like, hey, you have urethritis, but it's like, all the labs you put together and then, all right, so this is what the physical told me and this is what the labs told me, so therefore it's urethritis. And cystitis may coexist, which is urethritis, the thing that urine passes to in order to leave the body is inflamed, therefore they might have a risk for cystitis as well, or you might already have cystitis with urethritis. Treatment: antimicrobial. Like when it comes to stuff like this, you treat the cause, so what's causing that's what you treat with appropriate antimicrobial medication. So if you're sexually active, you make sure like you get to know who you're sleeping with, and you let them know like, hey, that's what I have, for them to get checked out if it's new. And then nursing care, what you expect the nurse to do is you assess for comfort, make sure the patient's comfortable. Still, I'll say educate about that because it factors like how they can do better next time. Understand the treatment. You make sure you explain the treatment to the patient or kind of like teach them stuff to do and not to do. They can also do sit bath, mostly for comfort. Not gonna cure anything. Hygiene teaching as well when it comes to like, for example, if you got urethritis or E. coli. And you also avoid irritants. So these products, like I know some people use to take care of the smell down there, so you just stop all that because it might cause that as well. That's it. All right, now we're talking about cystitis, a little bit different. So we were talking about the urethra, where the urine actually passes through in order to leave the body, was inflamed, urethritis. Now we're talking about cystitis, the bladder. The reservoir that actually contains the urine is inflamed, so that's the cystitis. So pathophysiology: bladder inflammation, like I just talked about, it most common bacterial that cause cystitis, E. coli, of course. Risk factors for cystitis: how somebody might have with cystitis: immobility. Make sure you turn your patient were on bed rest or can turn themselves. Calculi, urinary diversion, all them stuff can cause cystitis. Catheters can also cause cystitis, I guess, if they stay way too long or way too longer they're not supposed to. Radiation can also cause cystitis, which is a thing that I've seen with bladder cancer. But it was that when I was way younger. I used to be a medical scribe, and the place where I used to work at, there was like I'll say a good amount of men who used to come back after they got diagnosed with bladder cancer, went to radiation, and then later they will come back with bladder cancer. Well, not bladder cancer, but cystitis, bladder inflammation. Radiation, chemo, like all them stuff can actually cause cystitis, because what's radiation and chemo? So you have your cancer cell, they are directly attack this cancer cell, but by directly attacking these cancer cells, there are other cells that are being destroyed as well, and that's how we end up with cystitis. Women, yet again, are more susceptible. I don't really understand why women are very much more susceptible for cystitis. Well, from anatomical point of view or perspective is, urethra is outside, right? Um, the urethritis infection travel to the bladder, therefore I get the cystitis. So I kind of get where the cystitis is coming from in this case. Clinical manifestation, like how does cystitis manifest? So you have urgency, frequency, still you have your regular dysuria, pain with urination, hematuria. And what another thing that I also want to add is, like, when these men come back to the clinic or maybe at the hospital, one of the signs and symptoms they usually come back with is hematuria for cystitis, which is usually secondary to radiation. That's one of the things I'll never forget. You also have nocturia, peeing when you are asleep, spasm, incontinence. And how is the urine? Hematuria, like I said, some not out. Well, I don't want to say sometimes, because like all these symptoms, you don't necessarily have to have all them symptoms, but some people have some specific symptoms that other people won't. Right, so urine might look like dark, tea colored, or cloudy, signs of infection, and kind of like, hey, something's not normal. But a big thing that you guys gotta pay attention to is then the infection can travel beyond the bladder, and when the infection can travel beyond the bladder, the signs and symptoms patients usually come up with are fever, fatigue, and pelvic pain. So when you see stuff like this, kind of like a tip off, like, all right, the infection is past the bladder right now. The infection might be somewhere else. You're still gonna have your cystitis, but the infection might radiate somewhere else, and you gotta be on the lookout for stuff like this as well. Diagnosis: there is no specific lab that will tell you, like, hey, positive for cystitis, but you do your urinary analysis. See, I still struggle with some words. That's crazy. You do a regular urinary analysis, and then after you do your urinary analysis, you do a culture sensitivity, which will come back with what's sensitive and what you can use to treat the cause of the cystitis. That's it. Treatment for cystitis: you have your regular antibiotic. No, this I'm gonna do another video because this thing is way longer now. Treatment for cystitis: so you're gonna have your regular antibiotic. So either it might be a single dose or a 1 to 5 day regimen. You can also be given prophylaxis. When I was doing the lecture, one of the things that I do remember is prophylaxis is gonna be mainly when it comes like to urinary conditions, or when you're having infections. So it's gonna be mainly for recurrent infections, like if that infection is gonna come back and stuff like that. So in order like to avoid or diminish the chance of the infection to come back, so therefore they're gonna manage the infection with some prophylaxis antibiotic. And one thing that I do remember is it's not gonna be like those high there's antibiotic that cover like gram positive and gram negative at the same time. So it's gonna be like another kind of antibiotic that would just like singly or target this specific type of microorganism they're trying to kill, I'll say. Yeah. And then you're gonna have your regular analgesic, make the patients comfortable, and peridium. Peridium is really important. So it's usually for less than 2 days, and it's given for burning pain in the bladder and also to numb the bladder as well. Because when it comes to cystitis, the patient's gonna come with dysuria, which is pain with urination. So you're also gonna give the patient stuff in order to calm down a little bit this pain the patient has when the patient is urinating. And crazy thing is, I also learned that peridium is one of the not trip I'll say medication that the patient can actually have, right? But they also use TCA as well. This I'm gonna be covered a little bit longer, but I also wanted to say that because it was something new I've learned, that TCA can also be used, but it's not gonna be used at like the same regular like dosage you would have used, because it's like one of those antidepressant meds, but it's gonna be at a lower dose, but it also help with like bladder pain and stuff like that. I'm just throwing this out there because I'm going to be talking about it a little bit later. And then with peridium, the two new meds specific to this section: peridium for burning pain, and then pain urinating, and then to numb the bladder. You also have your ditropin for spasm, which is other name oxybutynin as well. So it's peridium and ditropin. You guys got to keep in mind. Nursing care, what are you gonna do? The nurse will ask the symptoms, causes, and understand. Encourage the patient to drink enough fluid, and you're gonna measure your INO. And when it comes to patient with renal problem, I'll do your INOs. Don't just do INOs. Don't rely on nobody to do your INOs. Do your INOs because nephrology might be on the case, and when nephrology is on the case, they're probably gonna be like, "What's the patient INO?" Just do your INOs for God's sake, just to have a good shift. I'll say. I'll technically just do my INOs on everybody, but hey, more specifically, like your urinary problem, do your INOs, because yeah, it's that important. Because you need to know how the kidneys to work. And you're gonna teach the patient for prevention technique. Cotton underwear, don't really wear tight jean and tight stuff. Wipe from front to back. When you got like your sanitation problem like E. coli, to avoid them stuff, and void after intercourse, like after you have sex, right? So just go to the bathroom. Don't just like knocked out and then not take a shower. Just go to the bathroom so you can avoid. That's it. All right, my beautiful friend. Now we're gonna be talking about interstitial cystitis. This kind of cystitis, well, we still have cystitis, but the cystitis is gonna be way much more specific to the internal lining of the bladder. That's where the interstitials come from. It's also called bladder pain syndrome. All right, let's dive in. So, pathophysiology. Chronic inflammatory bladder syndrome and then causes. So we don't really know like how people end up with interstitial cystitis, but if I'm put my 2 cents on it, take it with a grain of salt. I'll say if you have recurrent cystitis, I'll say there is a really likelihood for you to have interstitial cystitis eventually. Like, keep having infection, cystitis, and then boom. I think at some point you're gonna have interstitial cystitis. This just makes sense. I really don't know how it does, but it does. Signs and symptoms. You're still gonna have your regular bladder and pelvic pain, frequency, urgency. So still your regular dysuria, bladder scarring, which is one of the things we don't want, because the more scar tissue we have, the more likelihood we have for this thing to fail. So we don't want a scar tissue, because scar tissue, if you see it, there is a risk for making a clot obstruction. And when you do obstruction, what happens when there is obstruction? When there's obstructions, there's not enough blood flow. When there is not enough blood flow, blood not circulating where they have to go, things just die. And when things die, there is necrosis. And when there is necrosis, there is septic. So it's just like, we don't want that at all. That's the reason why we don't want it. But diagnosis, so how do you diagnose interstitial cystitis? So it's not like one of them things where you're gonna like do your UA and then you do a culture sensitivity and stuff like that. So this is gonna be a little different. So you're gonna do a cystoscopy. So you literally have to go in there to see the lining of the bladder. That's one of the reasons why I say it's specific, because it's the lining of the bladder, like the internal stuff. So you gotta get in there. You gotta go and see it in order to diagnose it. That's where the cystoscopy come from. Treatment. So you have interstitial cystitis. So how do they treat it? So there's multiple things they do to treat it. There is like I'm gonna divide it into 2 sections. So you're gonna have your more management side of things, and then you're gonna have your more radical side of things, which is where they're gonna remove the whole thing together. So symptom management, like you have interstitial cystitis, right? They want to manage it. So what do? They're gonna give you TCA. It's gonna be if you are eligible or qualify for it. We're gonna have to, if you're a good candidate for it. So you're gonna have TCA. Like I said, it's one of those antidepressant class medication, right? But there's gonna be a lower dose. The lower dose help with the chronic pelvic pain and the urinary frequency, like I told you about like 2 videos ago. And it's gonna be a lower dose, not the regular dose they would have give you if he was using in like a psych setting, for example. You're still gonna have your regular spasmodic, because we don't want bladder spasm, and histamine as well, anesthetic. And you also have CCBs, which is your calcium channel blockers. They are also used in order to decrease inflammation. That's crazy. Have NSAID, and one special med that I've learned as well in this specific section is Almiron, and it's given all, so it's also specifically for bladder pain. Right, so there's that multiple things they can do in order to manage your interstitial cystitis. But if after all that you have your TCA, you have your calcium channel blockers, you have your NSAID, you have your Almiron, you have all that, and it's still not helping, so they might do bladder stretching, which is where they're gonna overfill the bladder. in order like to relax a little bit the nerve ending, make them a little bit insensitive, so you don't have enough pain, much pain or pain as you would have regularly get if this was not done. They're gonna like fill the bladder a little bit past the bladder capacity. And in severe cases, if they still don't work, they might just remove the whole thing and do a cystectomy, which is where they remove the whole bladder. It's crazy, but hey, they gotta do something. The nurse, what the nurse gonna do? The nurse gonna teach, support and be empathetic with the whole thing, because the patient's gonna go through a lot. Not gonna lie, because they're literally gonna remove something you'll probably used to be seeing for your whole life. So they're gonna remove it, or there's something you feel like there's something wrong with you. You still don't know what it is. So of course, some people might just not take it well, psychologically. So you're also gonna avoid trigger food. Trigger food, it's a little bit tricky because not everybody has the same trigger food. So for some people, coffee might be a trigger food that might trigger the pain or make the pain worse. While other people it might be citrus juice. For other people, it might be things like alcohol, and for other people, it might be other things I have like carbonated drinks. So it's like best to avoid all them things if possible, or just if you're taking them, take them in like moderate consumption. Don't overdo it because you don't want the pain. Because yet again, there's nothing specific that can calm down or manage your pain. So it's pretty much like we throwing a bunch of things out there and kind of like see what works. Like literally throwing spaghettis against the wall or to the wall. So I don't really know what they said, but they're trying multiple things in order to make it work. So why would you take things that can make the pain more when when you know damn well that, hey, if you have this pain, there's a possibility for them not having anything that can make it go away. So yeah, just avoid these things. And that's all I got for you guys. I ain't got nothing else. Yep, that was interstitial cystitis or bladder pain syndrome. That's it. Alright, my friend, we're gonna be talking about pyelonephritis. See, that's crazy. Like, one of the big thing about this whole anatomy stuff is some stuff in the anatomy are just like weird. Everybody can say like, what the heck? We actually thought about this name and gave it to this thing. But when you are somebody, English is not your first language, right? This is even worse because you're like, damn, how am I gonna say that? Sometimes I really don't know why I'm putting this thing on the internet right now. Sometimes I'm like, when they're doing stuff like this in class, right? So I really don't want to talk because I know I ain't gonna say this thing right. So I'm like, I should shut up right now because I know if I say it, everybody gonna laugh. But I think over time I learned not to give a damn about it and still say it and get laughed on, I guess. Just move on. But still, pyelonephritis. Sorry. Pyelonephritis. Now we're going to be talking about pyelonephritis. There we go. Inflammation of the renal pelvis. So it can either be acute, just happen, chronic, have it for a really long time. And this is little inside of the kidney. And the reason why you guys need to kind of like visualize the inside of the kidney is because first, it's literally inside of the kidneys. And it will also help you understand the reason why we do the thing we have to do when it comes to a patient having pyelonephritis. All right. So first thing first, inflammation of the renal pelvis. It can be acute or chronic. Like I said, inside of the kidney. Keep that in mind. And causes can be ascending infection. Ascending infection. One of the things you guys need to keep in mind or remember is you're gonna have dysuria, pain urinating. It's not the only thing, but it's like one of the main things you can keep in mind in order to remember. Like, it's an ascending infection, and can cause recurrent UTI. When you have recurrent UTI, you're gonna have might be a possibility for cystitis, and you also know if there is multiple cystitis back to back, and back to back, there might be a chance for interstitial cystitis. And when you come to interstitial cystitis, when you have your bladder pain syndrome and the pain cannot be managed, you already know what's next is a cystectomy. They have to remove the whole thing. So I'm putting the stuff together right now just to show like how everything makes sense together. Clinical manifestations. So you're gonna have acute or chronic. Acute just happens. So you're gonna have your high fevers, right? Just to show you like, hey, the whole body is affected. Kind of like, like, hey, that's an infection. High fever, you're gonna have your chill, your nausea and vomiting, dysuria, which is pain, burning sensation when you're urinating. Also have your flank pain as well. But when it's too much more chronic, you're gonna have bladder irritation. Your whole bladder might be irritated, like I said, if you're cystitis, or you might have fatigue and also flank ache. The pain won't be as not chronic, but the pain won't be as intense as it would have been if it was acute, because chronic pretty much have the pain is there, you get used to it. But acute is that, oh my god, I have this pain right there, and the pain is it's hurting me. It's one of the worst pain ever, kind of thing. So pyelonephritis treatment, how do they treat it? So you're gonna have antibiotic, antiseptic, analgesic, and antispasmodic. Antibiotic. Make sure keeping in mind that you're treating the cause, like the reason why you have the pyelonephritis. Antispasmodic. We don't want bladder spasm, because it can cause what? Bladder leaks, which is uncomfortable, and then can also cause something else. I forgot. Let me go back and see. That's crazy. Why this thing doesn't allow me to go back? That's weird. Well, I guess 9 point. But yeah. So you're gonna keep going. So you have your antibiotic, antispasmodic, you have your analgesic, you also have fluid, a glass of water per day. You treat the obstruction if there is obstruction when it comes to pyelonephritis, because obstruction might occur, and there's a possibility for long-term antibiotic if you keep having the infection. What does the nurse do? The nurse do pain control, manage the patient's pain with the analgesic or the pain stuff provided by the provider. You assist the patient activity of daily living, because the pain, either acute or chronic, the patients might be will need assistance with activity of the living, such as like brushing their teeth, get help to eat and stuff like that. Just be with them and provide support and stuff. You're gonna monitor the fluid the patient is taking, because we don't want fluid overload. And what can fluid overload causes? This is just a little review. Can cause pulmonary edema. How do you look for pulmonary edema? How can you find out? You can listen to the patient lungs, and then if you hear any crackles in the lung, it's kind of like letting like, hey, this IV fluid you've been given, stop this fluid right now. And can also cause nephrotic syndromes, which is when you're gonna have like way too much protein leaving the body to urine being excreted, because way too much fluid yet again. Yeah. What else? I think that's it. I ain't gonna do nothing else. That was that's crazy. That is pyelonephritis. Pyelonephritis. That's it. All right, my friend. Now we're gonna be talking about a little bit different. The thing we're gonna be talking about right now is polycystic kidney disease. When it comes to polycystic kidney disease, one of the things you guys need to keep in mind is I was just sending a message. I'm sorry. When it comes to polycystic kidney disease, one of the things that you guys need to keep in mind is, say you got tissue, right? So when you have an organ, so you see like this smooth little tissue around the organ, or it's like as smooth as it is, right? So this whole thing is smooth. Just see a bunch of little bump, and the little bump you will see on the top of the like I'll say on the at the surface of the organ, or cyst. So instead of having like your regular smooth tissue, so you're gonna have multiple cysts around the organs, and that's where the cystic, I guess, come from polycystic, probably multiple cysts. That obviously good. Polycystic kidney disease, yeah, multiple cysts, like the normal tissue is being replaced by cyst at the surface of the organ, can cause renal failure, because it's just not supposed to be there. What can cause polycystic kidney disease? You're gonna have your regular hypertension, heart failure, and one of the things that you all guys also need to keep in mind is this is hereditary. So it's like one of them things that you can do genetic counseling in order to know it, probably if you have a trait for it. All right. Signs and symptoms. How does it manifest? So you're gonna have your dull, colicky flank, back, abdominal pain, and treatment. You're gonna treat the UTI. You're gonna control BP with two specific kind of meds. you control your BP with your ACE inhibitors and your ARB. ACE inhibitors, the thing that they do is they stop the body from producing what is called vessel narrowing hormones, and the ARB will stop the, it's not the body, but the ARB will stop the what? I see some cell to attack the receptors of other cell kind of thing. But these two medications are not gonna be at the same time. No. So it's kind of like what works and you give it to the patient kind of thing. And when it comes to ACE inhibitors, dry cough is one of them things you need to keep in mind. If you give somebody ACE inhibitors and you tell them like and dry cough, it's like one of them side effects. So it's like expected kind of thing. You know, if you have a question, this is like you just give the patient ACE inhibitors, and then all of a sudden the patient is like dry cough, and then you have your fever and you have other things, and they tell you like what's not normal. Probably not normal. It will be the fever. The dry cough is like expected when it comes to you give the ACE inhibitors, and then what you see afterwards. But I think maybe I read somewhere that says like in African American something, but this I gotta review and maybe do a video about it. All right, we are almost done. Almost done, I promise. Now we're doing acute glomerulonephritis. I'm not gonna try to say this thing a second time because I know I missed it, and then my ego will kick in, and then I'll try to say it probably 5 more times. I ain't got no time for that. Pathophysiology of acute glomerulonephritis. Glomerulonephritis. See, I did. So it's immune reaction yet again. So the glomeruli, you know, this thing that we have, I literally filtrate I'm reading my messages right now. Sorry. Yeah, I'm sorry. That literally filtrate the waste product, the excess fluid, and the electrolyte from the blood. So this thing is affected. Therefore, so when you have your glomeruli affected, it's usually secondary to a strep infection, right? So that's why, you know, having a strep infection is very important, because you have like this glomerulonephritis, and you also have endocarditis, if I'm not mistaken, as well. Things that you should be like, all right, strep infection, thinking about these two things. But for this specific acute glomerulonephritis, so secondary to strep infection. So your patient have acute glomerulonephritis, like how are your patient's gonna present? So one of the main signs of acute glomerulonephritis is gonna be periorbital edema. So you're gonna like see there, it's gonna be like puffy eye, not puffy eye specifically, but like these like gonna be puffy. So this will be like this kind of edema. And therefore, when you have a patient like this, I don't want to say you have strict intake, and strict I know, because you need to know how the fluid the kidney is doing. But when it comes to fluid, we're not gonna let them take as much fluid as, you know, somebody else who doesn't have this specific condition has, because we don't want to affect the kidney way much more then they're already affected now, because you're gonna see things such as protein in the urine, GFR will be low, creatinine will be high, and you're gonna also have the edema. Because you have your edema, you also need to get the fluid out, therefore you have to diurese the patient with diuretic. And what else from my note? Signs and symptoms, you will see tea-colored urine, your edema, periorbital, like I said, around the eyes. You can also have hypertension and hypervolemia as well, because very much more fluid, higher volume. Diuretic, and if strep is present, diuretic because you're trying to like diurese the patient, you know, get the fluid out. But if positive for strep, antibiotic needs to be given ASAP. Patient will be on bed rest, and there also will be dietary restriction, salt. Patient will also need to follow up with the provider afterwards when they get discharged from the hospital. What is the nurse gonna do specifically? Gonna monitor fluid excess, which may call for strict INO. So you're gonna have your strict INO there, and then you're gonna prevent immobility complication. You're gonna have edema. When it comes to edema, you also need to think about like a higher prevalence for pressure ulcer if patient is strict bed rest, and also teach the patient about anxiety support, because, you know, like all these things are kind of like new. Patient will be psychological affected So they'll think, some people will think, some people will be like, oh my god, I'm dying. Like, I ain't making fun of it, but it's kind of like new for them. So you gotta teach them different technique for like how to calm down and how to, you know, just see the good in the situation. Even sometimes like there is literally no good, or you literally can't see the good in the situation. You think you can see the good of the situation yourself as the nurse, but you know, like, kind of like be there with them and be empathetic, and I almost sympathetic. Be empathetic. There you go. You know, kind of like see where they are coming from, kind of thing. Yeah, and provide support. That's all they need, because some people just understand stuff different than the way you understand it. Some people make a big deal out of things, which, respectfully, you know, it makes sense because it's their life. They might think that they're dying, but it might be something that, hey, you know, that just needs to pass before they feel better. And when it comes to your patient having acroglomerarulonephritis as well, so as soon as the inflammation it resolve, things such as the GF4 and the burin, the creatinine will also resolve as well. One other thing that I was thinking about is, all right, GF4 low, burin and creatinine high, a fluid, no, because edema is already there. More fluid, what are you gonna do? You're gonna drown the patient. Therefore, fluid is not indicated for stuff like this. So you're gonna reduce the inflammation with medication, and then once the inflammation is resolved, you stuff like the labs will get stabilized. I'll say.